right, Renee, we are well over 100 podcasts going into this one today. And here we are again. How are things?
Well, it's been kind of crazy. We're still recording this in the middle of summer when normally we would be complaining about it being dry and hot. And we got the hot part, but man, is it wet. It's just been raining and raining and raining. So the craziest part, we keep mentioning that we had that water nitrate issue, so we couldn't water lawns, but we wouldn't need to water lawns anyway. So I'm probably with my HOA, we're going to save probably 5 grand just not watering this summer because we haven't. What are we going to possibly water? I've not seen it this green this late in summer in a very long time. So it's pretty crazy. So that's here. But before we get into this episode, Jason, what's happening on the farm?
Well, I have a problem with water, but it's water pressure. My pressure tank
Hmm.
from my well, I don't think is
Hmm.
maintaining the right pressure. And then this
Uh-oh.
hotel, I'm at a conference today, Renee. You can tell my background's a little different. There is no pressure on the shower head in this hotel. I travel a lot. We go to conferences. We've been in what, 20 states in the last year and a half. I have
Hmm.
never had a low pressure shower like I had this morning at this hotel. And I'm into Heartland. So, I would think that we would have a high pressure, kind of pressure washer type of shower.
Hmm.
No, it was just this little drizzle of like I don't know what it was, but I have to complain about the low flow shower head here today.
That's hilarious. That's really, really funny. So yeah, we should of all seasons, we should have more water than we know what to do with, and it can't come out the shower. So that's
Nope,
pretty nuts.
not this shower.
So today we're going to be talking to a new friend of ours that we met. I believe we met at the NARM conference in Alaska this year, and Dr. Jess Spohn. And Dr. Jess is one awesome person. I have learned a lot. I got to sit through their presentation on crisis care, took so many notes. And what's really fun is Dr. Jess and I have go back a ways. I'm a New Mexico State Aggie graduate and from New Mexico, and I haven't been back to New Mexico, but Dr. Jess is in New Mexico. So we hit it off immediately. We have some friends in common, and it's been really a fun conversation. So to kick us off today, Dr. Jess, will you just give us a history about what you do and who you are and what brings you in the world of crisis?
Absolutely. Thank you for having me. I'm Dr. Jess. I use they and them pronouns or my name. I identify as non-binary and queer and neurosparkly. My 10-year-old is the neurospicy one. So we gotta go back and forth with that. And I've been in New Mexico for about 13 years, originally from California. So Renee, you gotta come back to New Mexico. Jason, you gotta
I
come over
do.
here.
I, I like New
Um,
Mexico.
we also, like weirdly have green because it's been raining a ton and usually it's like dry desert
Huh.
heat. Right now it's our monsoon season, so
Yeah.
we've got,
Oh, yeah.
floods and things going. But I'm a independently licensed social worker and addictions counselor. I'm in recovery myself, over 10 years of recovery. And so, what I really love to do is work with individuals who are experiencing mental health or substance use crises. Been doing crisis care work for the last 4 or 5 years or so, ranging between here locally. I'm in Las Cruces, I'm in southern New Mexico, throughout the state and nationally with vibrant emotional health through 988, connecting all of the 988 contact centers with mobile crisis teams or similar services, kind of brainstorming if they are in a rural or remote area and they don't have access to that, what we can do to kind of problem solve. So I've seen crisis care from big to small, and I really enjoy being able to improve and increase equitable access to crisis care continuum services in my state.
Yeah. When Jason and I did a project with NAMI National, would be a couple years ago now, about 988 when it was rolling out. And the idea was for us to get together the different states that were really working in that area and kind of provide some counsel and some guidance to them about rolling that out. And but New Mexico was really in a fascinating conversation because we did have people participate from New Mexico, but what they were sharing is that it was very different how it looked in the rural areas versus in the urban areas. And so some places would look like, and we always talk about it being kind of gold stars on a map. If you looked at a map, you'd be like, oh, yeah, we have these services. But it could be in some places like one person who got it once upon a time. So they put a star where really it's not really accessible. And so we've talked about that a lot. So in your work there, do you have that where you have certain parts of your state that really are more robust and then other parts that are still pretty struggling at this point? Or how do you see that?
Yes, absolutely. And I think that that's happening across the country as well as we're kind of rolling out all of these different services. And, there was a big boost in funding for a little bit. And now we're seeing, possibly some changes that are coming up in funding availability. But in New Mexico, we've got Albuquerque, which is the biggest city. And it's got a pretty robust crisis care system, right? They use a combination of mobile crisis teams, crisis intervention teams, with law enforcement, or behavioral health. They've got the crisis center, right, in Albuquerque. And then as you kind of go outward, like down the state and out into the smaller areas, it gets kind of less and less. So I really appreciate that our state government has been really kind of emphasizing expanding crisis care, especially into rural and remote areas. And so we've been seeing kind of more services popping up with mobile crisis and with crisis centers, but it still isn't kind of throughout the entire state. For example, like in Las Cruces, we're the third largest city, in the in the state with about 120,000 people or so. And we've got a crisis center and we're still working on building mobile crisis teams, but we've got like a law enforcement, fire department based, crisis response team, but it's not 24/7, right? So we've got some of the services, but it may not always be 24/7, or in other areas of the state where the crisis center may not also be 24/7. And so it's kind of like pieced together in a lot of different places. Or you may have to travel 2-3 hours to be able to get to your closest crisis kind of service availability. And that may be really difficult, especially if you don't have the transportation, or if it's sometimes like in like the Four Corners area, some of the closest crisis response may be in another state, right? But then
Right.
your health insurance may not cover that if you even have it, right? So there's kind of lots of different pieces that are still missing, but we're definitely getting there and trying to get that expansion happening.
Would you explain to us your crisis center model? We go to a lot of places and we find that there's a different definition for crisis centers depending on where you're at. And so, just for clarity, what is housed within the crisis center in New Mexico?
Yes, I love that. I'm so used to working, when you're so used to working in it and you're like, oh yeah, I got the definitions, but from here to the next state over, it's probably going to be completely different. Our mobile crisis teams are defined as a two-person team that's able to operate 24/7, 365. And those providers can range from peer support workers, nurses, therapists, EMTs, and so on, and they go out and dispatch. Our mobile crisis services are expected to be able to be on scene to wherever that crisis is within an hour, unless you're in a rural or remote area, and then you can stretch it out to up to about 2 hours because some of our counties are pretty
Oh,
vast. And just getting
right.
from the office over there is going to be, a pain, especially if it's snowing or raining or
Mhm.
flooded or any of those kinds of things. Our crisis centers are called crisis triage centers. In other places, they're called psychiatric or mental health urgent cares, or others like crisis observation facilities.
Yep.
And they are for adults only, so 18 and over. And then an individual can come in. Most of them are 24/7. Some of them may be operating, on like 18, 16 hours, kind of depending on staffing and budgeting availabilities. But you can go in and they use the no wrong door model. So you can just walk in anytime for any concern that you have and get the help that you need, whether that's mental health related or substance use related, or like, I'm just having a really awful day today and I
Mhm.
don't know where else to go or what else to do. And they can provide you with some stabilization. Some of them allow medications to be on site. So maybe they can help you with some anti-anxiety medications, or if you're needing to see a medication provider, they can, maybe give you an update on your prescription if maybe you're running out. Because I know a lot of the providers, like if there's so few in these
Yeah.
areas, especially in rural areas, that, if you miss your appointment or if the provider reschedules, that you may run out of your meds before you are like able to see them. And then they'll do some referrals to community resources so that you can get the help that you need outside, in a destigmatized way. All of them are safe and confidential. I also forgot to mention with mobile crisis, there's two different types of teams. So there's mobile crisis teams, which serve individuals that are ages 14 and older. In New Mexico, the age of consent for medical and behavioral health services is 14. So
Oh,
it
wow.
can serve 14 and above. And then there's MRSS teams, mobilization, response, and stabilization services, which are youth-based teams. I don't think we have any that are certified and active in the state right now, but there's kind of a movement to be able to get some training and credentialing as an MRSS team in different areas.
Interesting.
So it's the same in Iowa with the two-person team, but we have found in our state there's a lot of people trying to demand the use of licensed professionals in that space, which Jason and I feel is a real waste of that license in many cases, not for the supervision portion of that, but for the actual piece when there's a lot of other people that could do the first response. And sometimes we have in many states, right, a limited number of licensed specialists, and then they're getting stuck in places that maybe not the best use of their license and their time and their expertise. And so then we can't use them for the other things that we need. So it is nice to hear that you've got kind of a broad group of who can respond, because that really makes it go further. And it sounds like in our state, we're even talking about, and I know in North Dakota also, partnering with places that are like the volunteer fire departments, because not everybody even have paid fire, ambulance, and so sometimes having some of them credentialed to help in crisis could actually expand that model further, because then they're already there, even if in a voluntary capacity, to cover the whole state. So, making those unique contacts have been pretty important for us anyway. So I'm wondering if you're seeing the same thing, like unique partnerships, or are you hearing unique stories? Like, Jason, what was that story about in Alaska? They were talking about using a four-wheeler for crisis services. Is that the one you remember? Remember
Yeah,
that
they
one,
just
that
called
story?
Bob if they needed to help to get someone out of a village that wasn't accessible and somebody needed some help, and Bob would just jump on his four-wheeler and ride out and bring Bill to the hospital. Sometimes it was more just that gritty, we got to get it done. And so we're not going to overthink it. And so I have to say, my mind immediately went to when you talked about MRSS teams. And, I agree we should have separate systems for children and adults. But in a crisis, I kind of think we just need someone to respond and someone to be there and someone to help to access the next core level of services that are necessary. So I really hate to hear that there are no services because the bar is so high we can't find anyone to deliver those services, which makes it even more inaccessible in those rural and remote areas.
Mhm.
Because if you can't staff it in your largest urban area where you probably have the most individuals, then it creates an issue, right? How do we find the balance between the ideal, which is what we really all wish for, and the realities of where we find ourselves? And how do we support the growing number, and especially in this case of kids who need those supports, who are struggling with their mental well-being and are going to need something with growing suicide rates, so on and so forth?
Yeah.
How can we do a better job with what we have, not necessarily what we wish we had?
Yes, exactly. And I think in Alaska, didn't they use like planes and things too
Oh
to get
yeah,
to some of the people?
planes, canoes, whatever it
I was
took.
like,
Yeah,
wow.
yeah,
Wouldn't think of that. You need a pilot's license to also be able to
yeah.
provide visa services. Like that's creative, if nothing else. Something that I really love about New Mexico is the creativity, right? So
Mhm.
in New Mexico, we've got some pretty dense, populous urban areas, but a lot of the state is rural, remote. Even where I live is just so, like, my county is just so vast, even though it's considered urban, like most of the county really isn't, right?
Mhm.
And so trying to figure out different kind of strategies to be able to meet the needs of people in crisis. And kid work with kids in crisis is definitely like a high up priority because there's so many services, like you were mentioning, right? There's so many services for adults, but there's not as many services for kids. I think that our state has a couple different CCBHCs,
Mm.
certified behavioral healthcare clinics. Oh my gosh, I can't remember the acronym. Hopefully that's close, close
Close
enough.
enough. Certified community, but there's two
There we
C's, but that's
go.
okay. It doesn't really matter.
It's like I'm missing a letter in there somewhere. Our state is really emphasizing standing up CCBHCs, which offer that vast range of services, which includes crisis care
Right.
and services for families and youth and children. And so in some cases, we have to just be as creative as we can. In one of the rural areas, I know they use Jeeps to go out to make
Mhm.
sure that we've got kind of all-wheel drive to be able
Yeah.
to get to whichever terrain, or, some teams may have like a truck. There's the availability of telehealth, which can
Mhm.
be both a benefit and a challenge. Because if you maybe don't have a licensed clinician that can go out or that's right there, but you need that service, since we know that there's provider shortages, especially for clinicians and in our state for peer support workers as well, you can at least access one on telehealth. But in a lot of the rural and kind of remote areas, you can't really connect to like the person's Wi-Fi, right? Or like the cell towers don't go, and so data doesn't really work. So can
Right.
you actually utilize the telehealth option? So that presents kind of its own, its own challenge. And the state allows for kind of extended times in case like your team, is responding to an area clear across the county and you can't quite get to it in 30 minutes, 60 minutes. A lot of the programs also use like on-call models for mobile crisis. So instead of just having people sitting in the office, for whatever shifts, they're just rotating with on-call. And then when a dispatch arrives, then they're activated and they go. So that kind of also gives a little bit of flexibility in availability of the different teams and kind of getting to the area, right? Because if you live closer over here to over there, then it's also not going to take as long when you're in that team of two. Other things that I think that we've seen that are really kind of unique with crisis care is with our crisis centers, and offering culturally relevant, culturally, really solidified care. So in one of the crisis centers in the Four Corners area, there's certain policies that are in place to really highlight the indigenous communities that's there, and being able to be respectful of cultural practices and traditions and different kind of strategies and like interventions, right, that they may be using, at home or, within their cultural system and their support network, to be able to kind of bring that in and blend it with mental health is something that I think is also just so beautiful. New Mexico is kind of a Spanish primary speaking state, right? So Spanish, English, but we also have, a wealth of indigenous cultures and like tribes and nations that are within the state. And so being able to kind of go back and forth between like Western, right, practices and traditional models of care is something that's so important, because when you're doing person-centered care, you want to do it centered around the person, not around your system and your own agency, right? So being able to really bring all of that in to holistically help somebody is so important, because if you just are like doing crisis services based on what you think everybody needs versus what they actually need and the skills and strategies that they can use, it makes all the difference in that de-escalation and stabilization.
Yeah, we were just working in North Dakota, and they've got a lot of indigenous population up there too. And there's a brand new hospital opened up, a really northern part of North Dakota. And one of the things we thought was very interesting was exactly what you just mentioned. They built it with the cultures in mind, with the colors, the schemes, the patterns, so that they was welcoming to the community, because they couldn't afford two. The Native American population couldn't have their own types of hospital, and then the small community really shouldn't have done theirs on their own either. So it became this really beautiful partnership where they could make everybody feel welcome. And so we're really hoping it's new, but we're really hoping it becomes sort of they want it to be sort of that hub, if you will, of where they can go for lots of different services. Because when in rural, Jason and I talk about this a lot, but you really need like the one go-to place where primary care can be there, your dentist can be there, everything can kind of go there, so people know that that's the place to go to get help, and they can get all kinds of help in that spot, because there's just not enough. You can't just get all these little small little places is not enough population sometimes to keep them standing. So you kind of have to work together. So I wanted to ask you a question. So on in 988, we've been talking about this. There's the three parts, right? There's the call part that most people were doing before they launched it. Then there's the mobile response, what we've been talking about. But the place to go in most states is the hardest part, is like we don't have places to go. So how has that third leg of where to go in New Mexico, how's that working for you guys? I know you talked about your crisis centers. Is that where they go? Like with a mobile crisis, bring them to there? Would they bring them to the hospital? How does that piece work?
It really depends on where you're at. And so part of the boost, right, that the state is giving funding for is for mobile crisis teams and for crisis centers. So crisis center would be crisis triage center or crisis units would be that third, the preferred part of the third leg of the crisis care continuum to be able to hand off from mental health to mental health, whenever possible. But they're few and far between in the state. And so, and even our hospitals, especially in rural communities, are few and far between. And with some upcoming, changes that are, posed with, administrative budgets federally, it may also affect our rural hospitals. And the availability of them and like funding to keep them open. So, for example, in Gallup, which is in the Four Corners kind of area, it is a like 3 to 4 hour drive for the closest psychiatric unit and hospital, which is why the crisis center is so important because it can serve as that kind of stepping stone or in between or catch. So that we don't have to send as many people to the ER or the individuals that are experiencing crisis in the community don't end up in jail, right? So it's really great for hospital and jail diversion, as well as, getting people the care that they need as soon as they need it. Because if you got to go to a hospital, most of the hospital, at least from Gallup to like Albuquerque, is like a 3 to 4 hour drive. Most people can't make that drive, and a lot of times the units there are full. And so they actually get flown by like medical helicopter down here to where I live, which is about a 5 to 6 hour drive if you're driving back, right? So, like, how do you even get home? And then people, get stranded. And so, crisis centers are so crucial
Mm.
to make sure that individuals are getting mental health care when they need it, how they want it because not everybody also meets criteria for inpatient psychiatric, treatment, right? So if you're not, experiencing suicidal ideation with a plan and intent, if you're not experiencing severe psychosis or substance use, then you may not even meet criteria. And if you're having a bad day, like where else are you going to go if you can't get a therapist appointment because the clinic, is overbooked because there's not enough providers and there's so much demand. You can't see somebody for 2 weeks, but you need something today. So that's where both mobile crisis and crisis centers come in, and then being able to offer those kind of like after hours opportunities, right? So if you've got people that are working in the rural areas in different, positions in day labor and farming and construction and all those kinds of things, they may have hours that are extended past the traditional 8 to 5, or you may not be able to take off time, right, during the day to go to this appointment and drive however many hours it takes to get to that appointment. So having service availability at, after hours at nighttime, at 4 in the morning, at, whatever time you need to do it before school, after school, really increases that access to anybody who needs it, no matter what their kind of lifestyle consists of.
We spend a lot of time talking about that continuum of care and what's missing in different states. And I just happened to we just did a podcast last week, actually, with Will Humble from next door in Arizona. And they've spent the last 5 years trying to implement acute care step down locked residential facilities. And there's been barrier after barrier after barrier. It was funded and then nothing was built. It's been refunded again. And he kind of talked about how challenging it has been to fill those gaps, because we all know that lots of people get stuck in hospital beds a long ways away from home. And so, how do we get community care back, right? Because we know folks are going to do better when they're in their own home communities. And sometimes we need higher levels of care in some of those communities, but it doesn't mean it always has to be an acute care hospital. And so, I think that, the crisis models that we talk about and having a place to go, we talk about the three-legged stool, but we also need a continuum of care around that to make sure that it can function, because when we shortchange the other parts of the continuum, then it puts too much burden on the parts that do need to function to support all the people across the community.
Yes, and when we think about hospital beds, we think about the emergency rooms as well, and people
Right.
just get stuck for days in the ER waiting for a bed, right? Because all of the inpatient facilities are either really far away or they're full. And so we're really, hospitals are great at what they do, right? They're great for COVID and gunshot wounds and car
Mhm.
crashes and heart attacks and all of those things. They're not built for mental health and for substance use detox and for psychosis and for suicidal ideations. And so crisis centers really are a pivotal component of all of this to keep people in the appropriate level of care and continuing to be in their own community without having to go too far away.
Yeah. So, Joseph, there's things that you would recommend. We always put a lot of extra like connections in the show notes for folks that look. So, in your community, what are those top 2 or 3 resources that you would guide people to if they want more information about what's available maybe in New Mexico, or what, services specifically you've been talking about today? Talk to us about some resources that if somebody were like listening to this and saying, I need to know more about this, how could they learn about what you're talking about today?
I love resources, and that's also what we do with Crisis is we give referrals to people to different kinds of
Mhm.
resources. So for the people that are trying to build these programs or are so lost in like what can I do and how can I even be a part of it, this or help. In New Mexico, yesnm.gov is a great resource. It's got all the different kind of like continuum of care, whether it's CCBHC, peer support, crisis care, and so on, and looking what all of the different kind of regulations are and requirements to be a provider. So that's New Mexico specifically. And then nationally, SAMHSA has a lot of really great tools and resources. There's a crisis technical training and assistance center. There are national guidelines and best practice documents that are available for adults and for youth and children specifically, right? So like the whole system and then youth and children, and some different kind of like survey reports and things that are out there on data, which includes kind of the challenges faced in rural and remote communities. And then I always love the Rural Health Information Hub. They've got a crisis response systems toolkit. And so that's specific, right? To rural and remote communities, which, we love when federal guidance comes out and statewide guidance comes out and all these bright, shiny things of like, this is what your system should look like. And then all of the rural communities are like, okay, but we don't have like 7 of these 10 things that we're supposed to have. What do we do? Right. So being able to see, information coming directly from people who know what it's like is also really helpful to kind of balance the two, which, we see that in New Mexico a lot. It's like, okay, here's the requirements. It's like, well, how do you expect us to get this? Is there any flexibility here? Right. So when in doubt, ask if there's
Right.
any flexibility with some of these things. Like if all of the buildings in your city like aren't going to meet the requirements for the space, like space setting, like, but
Right.
you still need one of these centers. How do you make it happen?
Yeah, we talk about that all the time, especially with evidence-based practices. Many of those are created in bigger communities, right? Even like when they call it the small number, we joke about it's not funny, but it is funny. Our small hospitals, when they talk about the evidence-based practice, like for small hospitals, they're talking like populations of 20, 25 people coming through, and we've got some small hospitals, if they get 3 or 4, we're having a good day. And so
Yeah.
you're not even on the same scale, right? And so we always tell people, not to just look for the perfect, but to continue to do something.
Mhm.
Something is better than nothing. And we really enjoyed, and I'm sure you did too, in Alaska. The best part for us is now when anybody says we can't do something because it's too far, it's too costly, it's too expensive, we just go, what? They can do it in Alaska. And so it's a
Mhm.
whole different ballgame now for us, because we're like, we've seen the big picture of no excuses. We can all do something, even if we can't maybe hit it exactly right. And you're right, there's lots of workaround opportunities, but people just sort of get sad and stuck, and they're like, we'll never do this evidence-based program, whether it's a community, an assertive community team or
Mhm.
whatever. And they're like, oh, we can't do that. We don't have all those providers. Well, maybe you can. You just have to talk about like what it could look like, because we don't. You're right. You just look at that and you have 3 of 10 and go, oh my goodness, how are we ever going to do this? But yeah, it's always most important to kind of look at that. So anything else you wanted to talk about today before we wrap up? Jess, thank you so much for your time. Is there anything else you wanted to
Yeah.
really hit on that maybe we didn't talk about?
I think just echoing what you were saying is that it's possible, right?
It is
It's
possible.
if there's a will, there's a way. And if nothing else, our local communities are great at being creative and using the resources that they've got with them. So it may not look like what it, should quote quote should be on paper, but that doesn't mean that it's not going to be doable, that it's not going to work well, that it's not going to be exactly what your community needs. So don't be afraid to either seek services if you need it, or to start having those conversations with community partners and agencies and local governments and state governments to being able to create these systems that we so need.
Agreed. Well, in this part of the show, we always run into the recovering politician self-care policy of the week, and this one's a wild one, but it has rained so much this summer, I gave up on even trying to straighten my hair. So we just got it cut to curl. It's impossible. Normally, my hair behaves like this only in Florida, maybe Georgia. But no, this year I would decided it was just going to be hot and humid every single day. It has rained in the month of July. It rained, I don't even know how many days in a row. Big storms, not small ones, big ones. Our rivers are full, everything's full. I mean, even where you are, Dr. Jess, it's green. I don't know who's not green in the continental US right now. We're all green. It's crazy how much rain we've all had. And so I just gave up because I was sick of trying to make it do what it isn't going to do. And it's such a great life lesson. There's things in my life where I'm trying to force stuff to happen, and it just isn't going to naturally go that way. So maybe I shouldn't be forcing it. So it really is a bigger picture. So Jason, before we go, is there anything in your world that's going to be different because of all the rain this year, besides the water pressure problem? Is there changes on the farm
Well,
because of all
I've
the
got
rain?
I've got all kinds of water related problems, it seems like. No, I I'm just thinking, like, I still have some tile to fix. I have no idea, Renee, but I'm not going to complain about the rain as a farmer and, going in and building some subsoil moisture. I'm going to be perfectly okay with that. One thing that's different is we're using drones more because we
Yeah.
can't get the
Mhm.
sprayers out there in the fields. And, my son's out droning. He's doing 16-hour days. I don't think he's slept for weeks because they've got more business than they know what to do with. Because, we have to adapt. And I think that's the key, right? Is if you can't control it, you adapt,
That's right.
and you find a way and you move forward. And so back in the
Make a
day,
way.
we'd park the sprayers and we wouldn't get that last pass of fungicide on. But today, we call in the drones, right? We used to use airplanes. We still use airplanes, helicopters, but we have drones. And so we have lots of different ways of solving problems. And so I think we can relate that to every aspect of what we do. If one thing's not working, then we just need to turn about face and find a different way to go about getting it done.
Couldn't have said that better myself. So before we go, don't forget to follow us on LinkedIn, Facebook, or YouTube. If you leave us a positive review, we'll send you a prize. Thanks, everybody. See you next time.